Morning. My name is Ali Zaman. I'm the VP of Marketing at Health Gorilla. We are an interoperability company based in San Francisco, and I'm excited to share a bit about our journey navigating this market of health information exchange. And I wanted to make this presentation a little unique. So I'm actually going to share a subset of our work that we do in Puerto Rico. So I really want to dedicate this presentation to our work in Puerto Rico. I think as mainland Americans, we often see headlines about some of the issues that are plaguing Puerto Rico, whether it's rising debt or high unemployment, which, to be honest, created a really unique environment for a young health tech company like ours to learn from and grow in. So I really want to share some of the insights that we took away from working with some of our major clients on the island. So if I take a step back, our mission is simple. It's to empower providers and patients with complete access to health data. Data liquidity in healthcare has been a major issue for many across the industry. And in many ways, interoperability is really an established market. EMRs by default are leading the charge in transformation. There are data sharing consortiums like Commonwealth and Care Equality that have built linkages between all the major EMRs. And then you have an array of vendors that really fill in the gaps. And this collectively represents major progress. But what I found to be troubling was that for underserved patients who are low income and their providers and their communities, they did not reap the benefits of interoperability. And when you think about healthcare innovation, you saw the bell curve of technology adoption in the previous presentation. And it's usually the well-funded health systems, the well-funded provider organizations that are sold to first and that tend to adopt new technologies because they have capital to risk on moving the ball forward. I can tell you that for Puerto Rican hospitals and providers, it was a radically different environment where interoperability was not on their radar until very recently. And because of the environment and the history of healthcare on the island, which we'll talk through, I think we learned that the pain points and solutions were similar at a high level for health systems in the US, but once you get into the details, it's radically different. And so we'll talk through what we learned there. And so the market that we built traction in and where we decided to focus as a company are markets where there are large volumes of underserved patients, patients that are vulnerable, at risk, perhaps uninsured or underinsured. And we have thought extensively about how to align incentives and make interoperability work for them. And so we've learned quite a bit about this from our experience in Puerto Rico, and we are looking to help bring these best practices and solutions to the US health system market. So a bit of Puerto Rico 101. It's a US territory. You have 3.3 million US citizens living on the island. To get to from one side of the island to the other takes about 2.5 hours drive. So most of the island's 68 hospitals are kind of competing with one another. All of the hospitals are operated by about a dozen systems. Outpatient care is predominantly performed at community clinics and independent providers. 80% of the population lives in San Juan. The rest of the island is pretty rural. And the island is $74 billion in debt. That's $25 million per citizen. And so most states have debt, but as long as there's an operating plan to recover, it's usually not a problem. But the economics of Puerto Rico make recovering from this debt very challenging. And this impacts the quality of healthcare that is received on the island in a very significant way. And so I wanted to walk you through a couple facts that might ground you in the reality of the quality of healthcare on the island. So the first fact you need to know is that Puerto Rico, despite being U.S. territory, despite being U.S. citizens, is very, very poor. Their median income is $20,000 per year, and compared to the poorest state in the U.S., which is Mississippi, the median household income is about half. And even after adjusting for the cost of living in Puerto Rico, it's a pretty challenging environment. When coupled with the unemployment rate in Puerto Rico, which is 9.2%, that's more than double the unemployment rate in the US. So this makes funding healthcare a very real challenge. Healthcare on the island is improving, but it's still not on par with healthcare on the mainland. This was a survey done by the Commonwealth Fund, where they found that half of Puerto Rico was on Medicaid. Most US states are 20%. I used to work with Rhode Island Medicaid, where 25% of Rhode Island is on Medicaid, and that was bankrupting the state. And so 50% is an incredible cost burden. The second survey stat in dark blue shows how patients perceive their health, which is a really important public health metric in a sea of data that's reported by providers and other entities that are not the patient. And so 34% of Puerto Ricans report fair or poor general health compared to 18% in the US, further just supporting the notion that the quality of care on the island is not where it should be. The third challenge is a rapid decline in population. And this is a very rare geopolitical phenomenon because there's a lot at play factoring into this. But the mere fact is, if you look at the Wall Street Journal analysis on the right-hand side, Puerto Rico experienced the largest decline in population globally between 2005 and 2015. Worse than war-torn countries like Iraq and Ukraine and Greece. And if you look at the chart on the left, the population has already declined 10%. So what does this mean for healthcare? This means less physicians available to treat patients, physicians being overwhelmed with their patient volumes, and patients losing any sense of continuity in care as either patients move to the mainland or physicians move to the mainland. And then the scary thing about this statistic is it's showing the population decline between 2004 and 2016, but Hurricane Maria didn't hit until 2017. And that was the worst natural disaster to hit Puerto Rico in modern history. So we'll talk about what the impact of that was to their healthcare market. So just recapping three major stats of healthcare on the island. So 50% of the population on Medicaid, but more importantly, reimbursement for providers is 60% lower for both Medicare and Medicaid, further incentivizing providers to just pack up and leave for the mainland, and creating a really difficult financial environment for provider organizations and hospitals. In addition, the 30% higher infant mortality rate, that's a really critical quality metric when trying to determine the overall quality of healthcare in a particular region. So a dire state overall. So interoperability on the island is still in the first innings, given the reality that 50% of providers are still on paper. Most outpatient care happens at the independent practices. Most of the health systems are using the Meditech EMR, but federal incentives to use EHRs are much lower on the island, and there is no island-wide information exchange. There have been previous efforts to build an HIE on the island and connect every provider electronically, but they have either failed or did not pass ONC certification. And today there is no real way to receive data from other providers unless you own a fax machine. So just summarizing the environment of Puerto Rico, you have extremely high debt, an impoverished, declining population, half of patients on Medicaid, half of providers on paper, and the base healthcare infrastructure needing to be built. And then Hurricane Maria hits. And this was a Category 5 hurricane at its peak strength, sweeping over Puerto Rico and the US Virgin Islands, becoming the worst natural disaster in history to affect that region. It was also the most expensive hurricane in history, $91 billion in costs. So this is the before and after the hurricane. This is San Juan, where 80% of the population lives. And you can see the glow after the hurricane was much less. So what was the impact on healthcare? So it was pretty substantial. A third of the island's hospitals operated without electricity for 3 months after the hurricane. Most community health centers did not have access to clean water and power. One of our customers told us that there was a major community health center called Hospital Castanier that was without power for 8 months. So this hurricane served as a catalyst for many physicians who are considering moving to the mainland to just pack up and go. So a significant percentage of the physician workforce emigrated to the mainland. There ended up being a 9-month wait time to see a specialist and 13-hour wait time for hospital admissions. So this overall was a very dire experience. And after months in this situation, many leaders on the island recognized that healthcare was going to be a core part of their revitalization investment in the island. And key to that healthcare investment was going to be interoperability, getting an established interoperable network, and most importantly, getting clinical data in the cloud. So let's break out the journey towards interoperability in Puerto Rico. There were a couple pretty fundamental issues that we still see here in the US that they experience there, where patient data is scattered in bits and pieces across multiple disparate IT systems. Fax was still the standard by which providers exchange medical information. And providers need access to an aggregated data set, not just to inform care, but also to get paid if they were at risk. So we established our first partnership on the island with the Puerto Rico Primary Care Association Network in 2017, and I'll refer to them as the PCAN. So the PCAN is a network of 20 federally qualified health centers operating 98 clinics across the island. Geographically spread out so that virtually everyone was in reach of a clinic. Many clinics were actually mobile clinics, so they actually had wheels and they would go to places where traditional physical facilities could not reach. And they were responsible for the care of 360,000 patients, which is roughly 10% of the island, all of whom were deeply impoverished, underinsured, uninsured, unstable housing in some cases homeless. And while the population of the island was declining, the PCAN is actually reporting an increase in patient volumes. So we partnered with them to implement an interoperability engine for their network of federally qualified health centers that could accomplish a couple things. First, we needed to aggregate the comprehensive clinical history for every patient. Second, we needed to develop reporting and analytics to improve access to care, to create really actionable insights for providers. And third, we needed to improve care coordination across the clinics that were a part of the PCAN network and provide island-wide visibility for the managing entity that was responsible for public policy, technical support, and research opportunities. So integrating and normalizing clinical data is complicated, as many of you know. And so we implemented a platform that could integrate with their IT systems and normalize data regardless of the format, whether it was HL7, JSON, DICOM, FHIR, virtually any data format. And we normalize it into a CCDA and then use an algorithm to match different files to a single patient. Then we'd store this data in a data lake, and standardizing the data set was a really fundamental first step for interoperability. And so there's a lot of work ahead to really make the highest impact, but we're lucky and fortunate to have worked with the PCAN on one of the largest and first interoperability initiatives on the island. And of course, this is powered by AWS. So back to reality, and leading into our next partnership on the island, the US Census projected a dramatic decline of Puerto Rico's population after the hurricane hit. And measuring the decline was actually a very significant issue because no one knows how bad it's going to get, and it's really hard to track patients leaving. So CNN did an investigation that looked at outbound flights around the time of the hurricane, and they were matching it to FEMA applications and address changes and school enrollments. And the goal was to estimate the number of Puerto Ricans that stayed on the mainland. So you can see where most of the Puerto Ricans who emigrated moved, so mostly Florida and New England. The reason I bring this up is because patient movement and relocation after natural disasters is actually a major healthcare issue because the patient often loses contact with their providers, making it difficult to coordinate care. And most importantly, they lose their entire clinical history when they leave. So for someone with chronic disease, it's absolutely critical that they have a record of medications and allergies and encounters and their social history. It's very fundamental information that would inform their care. But in the case of those in Puerto Rico, many clinics were shuttered due to physical damages. Patients lost contact with their providers because many providers packed up and left. And without electricity, it was impossible to fax records off the island. And we constantly think internally that if clinical data and claims data was in the cloud, we would not have this issue. And it was interesting that one of our customers told us that Holyoke Health here in Massachusetts saw 400 patients that emigrated from Puerto Rico. And they were treated without any knowledge of their past clinical interactions, likely leading to duplicative tests, procedures, labs, and likely increasing the cost for the state Medicaid budget. So this led to our partnership with the National Health IT Collaborative for the Underserved, and we called it the Medication and Immunization Management Initiative. So we set out to offer solutions for that ensure patients who relocate due to natural disasters receive coordinated care wherever they go. And secondly, that they can hold access and control their entire clinical history. And this was leveraging technology that our mobile app was built on, which allows patients to store labs, imaging, and other critical health information fully accessible at their fingertips without needing patient portal credentials for different EHRs. Patients who use our app sign a HIPAA proxy, so they actually get access to a larger set of clinical information that you would if you were to log into your patient portal. This app is available in the App Store, by the way, if you'd like to download it. So in December of 2018, we signed a new partnership with Menonita Health System, integrated 5-hospital system and health plan in Puerto Rico. They actively manage 240,000 patients. This system played a really critical role in our growth strategy as a company because this was one of the first systems that came to us not just wanting to leverage our data normalization engine, but also to connect to Commonwealth and Care Quality, which are these big data sharing consortiums. And this was a really critical piece of their interoperability strategy, being able to tap into a larger network and access medical records to inform patient care. In fact, just a few months ago, we became the first vendor to serve as a connector to Commonwealth. So organizations could work through Health Gorilla to access these networks without the implementation costs and the technical burden of working with each individually. So following our learnings with Menonita and working with some of the larger systems, we find ourselves learning about the needs to maintain and grow a large affiliate network. And so a growing number of health systems understand that to grow market share, it's critical to engage and drive loyalty among providers that aren't necessarily employed. And being able to ingest that data electronically from the affiliate network is not just to inform patient care, but can really drive some very interesting insights that we believe will reduce duplicative testing and procedures, standardize care not just within the system, but across the referral network, and ultimately lower costs. And so we welcome conversations with health systems that are experiencing this issue of having limited visibility into their affiliate network, and therefore limited strategic insights in how to grow and foster that network. And so our play is to connect independent providers that are affiliates with the health systems electronically via Commonwealth and Care Quality in our own network. And if anyone's not in those networks, we will essentially build a direct feed into an affiliate data lake where that data becomes normalized and queryable and integrated with the health system's in-house data center. So when we talk about data, what are we talking about? It's basically everything in a CCDA file, so ranging from labs and imaging to family history and clinical encounters. And to further deliver value to providers, we launched Patient 360, which allows providers to tap into these data sharing consortiums and retrieve medical records electronically for their patients from nearly 90% of acute EHRs and 60% of ambulatory EHRs. Epic, Cerner, eClinical, Athena, they're all a part of these networks. And so my dad is actually a neurologist at Jefferson Health, and his current process to get clinical data for his patients includes asking the patient directly. The patient might say, you know, they got an MRI at Virtua Health, they got a CAT scan at Penn, they got labs in urgent care clinic, and then the office admin has to call each place, fax the patient authorization form, receive the documents over fax, upload into EHR. There's a whole administrative burden associated with just getting clinical data that any provider is familiar with. And so this provides an automated way of getting clinical data. And so we think it'll help providers who treat a large volume of new patients where you need some type of clinical context before that patient walks in the room. And this product is live. So if you're a provider, you can go on Health Gorilla and start querying patients. The one caveat is you can only query for treatment purposes. So for executives at provider organizations, health systems, independent practice associations, there is a set of insights both on market performance, which will show in aggregate sources of patient leakage and retention, and as well as clinical insights like being able to review duplicative testing and procedures, monitor provider performance with actionable insights that lead to better quality and lower costs. So in closing, we're seeing the momentum increase in light of ONC's data blocking rules that were also highlighted in the previous presentation. This was announced by Don Rucker at HIMSS, and while still a draft, they have stated that any healthcare organization contracted with Medicare must share data electronically with patients. Hospitals must notify the care team electronically when patients are admitted, discharged, and transferred. And patients who request their records must receive it for free. And so, we're really excited to be a partner to organizations that are not just looking to comply with these rules, but are really looking to raise the bar through interoperability to provide a new level of care to patients that are underserved, low income, at risk, and vulnerable. And so I'm really excited about the road ahead. I'd absolutely welcome a conversation with health systems and other provider organizations to dive in further about, how can we better engage remote or affiliated providers and get full visibility into care. Thank you. My email's on the slide if you'd like to get in touch.